Welcome to Day 3 of Key Insights in Lymphoma Myeloma 2017, an international conference on hematologic malignancies. I'm Morton Coleman, chairman of the conference, and with me I have my co-chair, Dr. John Leonard, also of Cornell University, who was the chair of today's session. John, it was an exciting day today. I learned a lot of new things and a lot of exciting things. To me, the exposition, if you will, on CAR T was perhaps to me the most exciting one item I heard. What is your take on CAR T? Where do you see it going? Where do you think it's going to be in our armamentarium in the future?
Well, Mort, thank you. Before I get to that, I just want to thank you for really a great conference. And I think that this is something that you've put many years into, every year putting it together. We get, I think, the best speakers around the cutting edge topics, both science and practical clinical care. I think we had over 1,000 people here this year, so I think it's really a tribute to you, and really I think a key, something that the community loves. People just come up and say what a great meeting this is. So for the audience, if you haven't had the chance to be here, it's really great to, a great meeting to try to attend. But CAR T cells.
Well, thank you, John, but I really couldn't do it without my superb co-chairs, and you certainly rank amongst them for sure.
Well, thanks.
Thank you for all your effort in making this conference what it is today.
Sure. So CAR T cells, I think, are something that whether you're following the latest literature at meetings or reading the New York Times or many other newspapers or the news, you have to know about it as a practicing physician. To some degree, I think it's more spending time with patients that are interested in CAR T cells and are not appropriate for them, as much as it is to get the right person on that therapy. But to recap for the audience who may be a little less familiar, the concept of a CAR T cell is really to mobilize and collect peripheral blood T cells from a patient, then take those cells and through various commercial procedures and different companies, essentially transduce those cells in a way that can both make them more powerfully immunologic, meaning essentially co-stimulatory molecules of various types inserted into the genes so that they are more active as T cells. Also having a part of the construct that allows them to better bind CD19, which is a target on T cells. And so these then re-engineered T cells, typically after some form of chemotherapy, to make space so that the cells can proliferate and expand once they're infused, are infused into the patient. And obviously then the intent is that they go on and derive or develop an anti-lymphoma effect through these various mechanisms. So this has been done by a lot of different investigators, a number of different groups. It's been approved first in ALL, childhood and adolescent ALL, and now more specifically in resistant lymphomas and relapsed lymphomas, particularly in the diffuse large B-cell and aggressive lymphoma subtypes. So I think that this is an exciting area. I think that it is clear that there are some patients on the various trials who have had very limited other options, and this has been a home run for them, meaning that it's really rescued them from really the lack of other options and a very poor, desperate clinical situation. And in some of the early studies, some of these are remissions and responses that have lasted years, albeit a relatively small number of people. And most of the pivotal trials that we talked about today and which have led to the approval specifically have very short follow-up on the order of a year. So the caveats of that are clearly that we need more follow-up with these current constructs as they are. The process is one that really requires or results in some patient selection, because various clinical trials, the accrual was a staged accrual. There were not always spots available. So you're left with some patients in those trials who were the ones who could wait to get the treatment. And therefore there are some selection issues in that in various trials there was anywhere from a 10% to a 20 or 30% dropout of people that were enrolled or registered but didn't end up getting the treatment. That being said, with all of the products thus far that have been studied in large cell lymphoma specifically, The response rates are in the 60 to 70% range. The complete response rates seem to be in the 30 to 40% range. And the durability of those seems to be quite meaningful. And the data suggest, although again more follow-up is needed, that if you go into a CR, those CRs tend to be durable. There is a cost to that in the toxicity, and they're the biggest toxicity which practitioners are mostly going to be referring for these studies, or these treatments I should say, rather than treating them themselves. At most centers, it's the transplant center that is really conducting the treatment and monitoring the patient. These are associated with a cytokine release syndrome, which results in a robust immune response that is associated with cytokine release that can result in fever, encephalopathy, in the most severe cases, brain edema. And so this can occur a few days after the treatment, can in some cases require hospitalization in an ICU, and so on. And so this is not without cost. So how do we put all this together? I think that it is clear that this is an exciting technology. It's an exciting treatment option. It is clear that there are some patients that seem to have, what we would call heroic responses. But I think from the practicality for an individual practitioner who may say, I want to send my patient, or should I send my patient to get CAR T cells? In reality, I think at this point, there's about a 1 in 3 chance the patient is going to have a very durable remission. That is, they get to the treatment, they respond, that respond is a CR, and that CR is durable. So for someone who has minimal to no chance, a 1 in 3 chance is pretty good. On the other hand, the fact that 2 out of 3 people are probably not going to achieve that, at least at this present time, says that there's a lot more work to do. And to be clear, there are relatively few patients over the age of 70, and certainly I think probably nobody in the age of 80 or older who are getting these treatments. So there is a toxicity issue there. So that being said, as you note, this was really a highlight of the meeting because everybody's asking, this is a new approval, and I think that the challenge for the future is going to say, okay, who is the right patient to get this? Who are those 1 out of 3 patients who are going to do great with this in our current state? Number 2, how can we make it better? How can we make it more effective and less toxic? And then number 3, how are we going to combine these with our standard therapies? And as of right now, it's really for people who have been through other options and are chemo refractory, have limited effect. But the future questions are going to be, is this going to replace autologous stem cell transplant? Is it going to be combined with autologous transplant? Is it going to be a consolidation after R-CHOP or something else? And I think those are going to require more randomized trials to take it from something that we just use as kind of a Hail Mary at the time when nothing else is working versus a routine standard part of therapy as auto transplant has been in the past at least.
Yeah. Well, it's clearly being refined even as we speak.
Right.
We now have ways of handling cytokine storm. And I could foresee one day when it would come up further in that treatment schema.
Certainly.
But right now it is a option for people who have nowhere else to go.
That's right.
In those patients who have refractory or resistant disease, auto transplant does not offer them very much, and certainly allogeneic doesn't offer them anything. So it already has carved out its niche. So you one day would foresee that maybe it'll be brought up, if we can refine the therapy, make it even more effective. You could see they could be brought up even frontline in patients, let's say, with double-hit lymphomas. Could you foresee that someday?
Certainly, I think that one way of looking at it is to use it in patients that have a very low or relatively low cure rate. So I could envision a day where, say, in double-hit or some other identified subgroup, which we may or may not be able to identify within the standard large cell lymphoma patients, where the cure rates are quite low. I think that, as you know, the cure rates in large cell lymphoma in the prospective studies are in the 70-75% range. So to replace that, it's going to have to work pretty well, particularly since in some ways it's more toxic than R-CHOP. So I think that's going to be the sweet spot. I don't think it's going to entirely replace R-CHOP. I think it will, in some people with resistant disease, make R-CHOP work better or could augment R-CHOP in some way. But again, who those people are, it's hard to say. But there's no doubt, and there are some randomized trials that are being planned that are really asking the question that you alluded to. Auto transplant, even in the best group of patients, only ends up curing in chemo-sensitive young people, a minority of patients. And so if we use this instead, would we do even better? And I think that's a very fair and important question to look at.
One of the issues that's been bandied about is how can we improve on R-CHOP? With all the additions that we've had, there's been very little improvement to R-CHOP, R-CHOP-R if you wish. When would you use something different other than R-CHOP? What situations would you currently use something different? And where do you see we are improving on R-CHOP, some of the newer drugs which you heard discussed at the meeting?
Yeah, I think that's a great question. And for people in the audience who see lymphoma patients, diffuse large B-cell lymphoma is the most common type of lymphoma. So that's the most common regimen that's used. And so you really, in practice, need to know when do you use something else. I would say that within the molecular, so there are the clinical subtypes and then there are the molecular subtypes. And I think we can break it down into that, and I'll briefly touch upon those. So primary mediastinal disease seems to have non-randomized data suggesting that dose-adjusted REPOC might be better. So as of today, in primary mediastinal disease, I would do that. In limited stage disease, I think you're going to use R-CHOP. It raises the question, can you get away with less treatment, particularly if the PET scans are negative? Can you give 3 or 4 cycles of R-CHOP? Disease where there is a high risk of central nervous system involvement, multiple IPI risk factors, adrenal and renal involvement seem to be high risk. Up to 15% of those patients with large cell lymphoma will have CNS disease. So adding methotrexate, perhaps day 15 methotrexate, along with the R-CHOP is something that we would do. And then certainly in testicular disease, that's a scenario where there's data on radiation of the contralateral testis and central nervous system prophylaxis. So there's that group of clinically defined lymphomas where you're going to do something more, and that tends to be R-CHOP or a twist on R-CHOP plus, in these cases, central nervous system management. Then there's the other scenario of, okay, what subtypes of large cell lymphoma that are molecularly or pathologically defined where we're going to use something more than R-CHOP. And I think as of today, the biggest problem in large cell lymphoma is the double hit lymphomas, where you have FISH-defined translocations involving MYC, BCL2, BCL6, or some combinations of those. And that's a group of patients that have a poor outcome with R-CHOP. We have some evidence, not fabulous evidence, but reasonable evidence suggesting that dose-adjusted REPOC might be better there. On the other hand, the double expressor lymphomas, meaning those that don't have the FISH-defined translocations but have protein overexpression, with those patients, dose-adjusted REPOC does not seem at this point to be better. And so we are looking at new targeted treatments, things along the lines of venetoclax, the BCL2 targeted drug. And those patients tend to also be the activated B-cell subtypes of large cell lymphoma, where we have a number of different targets. So far, we've done studies that you were part of as well, looking at bortezomib in those patients. Doesn't seem to make a difference in the ABC subtype. But we have studies going on looking at lenalidomide and ibrutinib in the ABC subtype of large cell lymphoma. And there are randomized trials. We're waiting on the data. And I think those markers, that cell of origin, has been pretty powerful in retrospective studies. But in prospective studies, where we do have some patient selection issues, that's been a little bit less clear. So at this point, we need to await the randomized data to better define if these targeted agents will make a difference.
Yes, with that in mind, where do you see venetoclax's role? Where do you see ibrutinib's role in indolent lymphomas and perhaps even in aggressive lymphomas?
Well, I think venetoclax has been particularly useful in CLL, as you know well. I think that it has had activity in small studies looking at mantle cell lymphoma and in follicular lymphoma, and it's been combined with chemotherapy. And so we kind of await those randomized trials with bendamustine combinations or CHOP combinations to see what venetoclax does in most of the other lymphoma subtypes. Certainly ibrutinib and lenalidomide have activity that is, I would say, modest as a single agent in follicular lymphoma. I would say that they're also modest, although ibrutinib is approved in marginal zone lymphoma as a single agent. You're still talking about 20, 30, 40% response rates, but that can be meaningful in some patients. And so I think those drugs, the bigger impacts are going to be in combination. We have a number of randomized trials using antibody plus ibrutinib, antibody plus lenalidomide, whether it's rituximab or obinutuzumab. And those data are quite promising, and we're awaiting those comparative phase 3 trials. And then, of course, as we mentioned, in large cell lymphoma, particularly in the ABC subtype, ibrutinib and lenalidomide appear to have significant activity, but again, we need the randomized data.
Yes, we had a very robust debate today on how would one approach large volume follicular lymphoma. Would one use CHOP-R or would one use bendamustine-R? What is your take? How would you treat this patient initially? Would you use bendamustine or would you use CHOP as the chemotherapy backbone?
Yeah, so I think there are in a high tumor burden or large volume follicular lymphoma patient, I think you have 3 questions. If you're assuming you're not going to use antibody alone, it's really what chemo, what antibody, and what maintenance. Those are really the questions. So I'll work backwards on those. I tend not to use so much maintenance in follicular lymphoma because it's progression-free survival benefit, not overall survival benefit. And I would say that there is some added toxicity, and when you use maintenance therapy, you're taking a 6-month treatment or a 4-month treatment if it's R-CHOP and turning it into a 2.5-year treatment. So I tend not to use so much maintenance. That's my preference, although I know some practitioners use maintenance, and there are certainly data supporting that, again, with progression-free survival. Then working backward, which antibody? And we have data that from the gallium study looking at obinutuzumab, looking at rituximab, suggesting that there is a progression-free survival benefit if you're using chemo plus obinutuzumab versus chemo plus rituximab. So the issues with that, so many people are now, and there's, I believe, some FDA support for the use of obinutuzumab as initial treatment. The difference there in making that choice is that those data are without maintenance, number one, and so if you're not using maintenance, you don't really have much obinutuzumab data. And number two, some people are using the subcutaneous rituximab formulation, which you don't have with obinutuzumab. So if you've decided in your practice to make a little bit more patient-friendly treatment regimen, you're going to use the subcutaneous rituximab. You can't use obinutuzumab. We don't have that formulation. And then finally, working backward, which chemotherapy, and in the high tumor burden.
With regard to the antibody, my understanding is there's still no difference in survival between the use of the antibodies.
Right.
And I understand that with bendamustine, it doesn't seem to make any difference whether you use obinutuzumab or rituximab, that most of the difference, I think, is seen with CHOP. But let's work backward and tell me, how would you view bendamustine versus CHOP, in your opinion? There's no right or wrong answer, of course.
So in my opinion, I think that bendamustine is better tolerated from the standpoint of the acute toxicity. You don't have alopecia. That's a big issue for patients. And I think that the vast majority of patients, if I'm not suspicious of transformation, typically defined by a PET scan being low SUV, or ruling out that high SUVs are transformation by a biopsy. In those cases, I'm typically using bendamustine rituximab as my initial treatment, again, because the toxicity is less. Now, some have argued that, and that was, I think, alluded to in the debate today, which I know was spirited, when you use maintenance, particularly, is there more toxicity of bendamustine-based treatment followed by maintenance? So is that an argument against bendamustine? Is that an argument against maintenance? Is that real? I would say that doesn't really influence my thinking. I understand the thought. There are in that gallium study a few excess deaths. It's still very low. If those were large numbers of deaths, clearly that would be affected in the ultimate data. And so my perspective is that I tend to use bendamustine and rituximab as initial treatment.
And again, the overall survival is not impacted one way or the other.
Exactly.
And of course, you could reserve your CHOP if there should be transformation at a later date.
Exactly.
We heard a little bit, in fact, we heard quite a bit about EZH2. Where do you see this playing a role in the future of clinical medicine?
Yeah, so EZH2 is one of several epigenetic therapies. EZH2 mutations are seen predominantly in germinal center B-cell lymphomas, so you see them in follicular lymphomas and in a subset of diffuse large B-cell lymphomas. The majority of those are what we call wild-type EZH2, meaning that they're not mutated with respect to the EZH2 gene, but there are mutated EZH2 patients or tumors within the GCB subtype and within follicular lymphoma, both of those typically being germinal center in origin. And so the take-home data is that there is an EZH2 inhibitor that has been studied in some large clinical trials that has relatively modest activity in large cell lymphoma, whether or not the patient is EZH2 mutated or not, has modest activity in wild type or non-mutated follicular lymphoma, but in follicular lymphoma with an EZH2 mutation, the response rates to this agent are quite high, in the range of 80 to 90%. So that's quite exciting to have a biomarker for a drug that has an 80% response rate plus in that group of patients. And so clearly that's a place where this drug seems to have a future. It's oral, it seems to be well tolerated. There are questions around this because we don't know how the EZH2 mutated follicular lymphoma patients do with bendamustine, with lenalidomide, with ibrutinib, with other agents that we commonly use in follicular lymphoma. So is this a drug-specific phenomenon or just a marker for a better follicular lymphoma patient? Time will tell, but there seems to be some sense that this is a nice biomarker, and I think that's in the near term. That's where I think the future is going to be.
I'm getting the suspicion that we're seeing the advent of personalized treatment, and looking at whether the EZH2 is mutated or whether it's not mutated.
Correct.
Now, one of the other subjects that has come up is how to approach T-cell lymphoma,
Right.
And what is the role of autologous transplantation. Again, there were several talks on that, and we'd like to know your take on how do you approach your aggressive T-cell lymphomas, otherwise not specified.
Sure. So I think that's a great question, and in a nutshell, it has not become more clear in recent years. And I think if you asked me this question 5 years ago, it'd probably be more or less the same. I think that CHOP is not great therapy. There's some evidence, perhaps a little more firm evidence now, that adding etoposide to CHOP, whether it's CHOEP or some other version such as EPOC, is a little bit better than CHOP. Those are not randomized trials largely, but different series. So I would use an etoposide-containing regimen as induction. I think there are conflicting data on, do you just observe the patient? There's no data so far that maintenance therapy with any of the new T-cell drugs makes a difference. So the question is, do you observe the patient? Do you do an auto transplant? Do you do an allo transplant? And I would say that in young patients who have a good remission, typically I would do an auto transplant in first remission in T-cell lymphoma. But I would say that the data supporting allo transplant, I think, is not very strong over an auto transplant. And honestly, the data of an auto transplant over observation is not very strong. So I think you have to be honest with the patient. I think that the patient is fit. We know that these are bad diseases if they relapse. So I think that in most cases I would do an auto transplant in first remission. But I think you have to be not dogmatic about it, but pragmatic about it, and really have a discussion with the patient and individualize it to the fitness of the patient and the nature of the response that they have.
And finally, one of the issues that has come up is how to best use PET scans in planning your treatment for Hodgkin's disease as well as for large cell lymphoma, particularly limited stage disease and so forth. How do you use PET scans? Let's start off first with limited stage large cell lymphoma.
So I would say limited stage large cell lymphoma, the best data suggests that at the end of your treatment, or which may often be after 3 cycles, or at least a planned 3 cycles of treatment, if you're PET negative, your outcome is likely to be pretty good. So in someone who is PET negative after 3 cycles for limited stage large cell lymphoma, I would typically perhaps give them 1 more cycle of treatment, stop at 4 cycles, and go from there. If you're a limited stage patient that's PET positive, on the other hand, that is an unfavorable outcome. Those patients have in the range of about a 60% in some series long-term remission, which for limited stage disease is not particularly impressive. The question is, what do you do with those patients? And I don't think we know the answer, but I probably wouldn't stop at 3 or 4 cycles. I would probably radiate that patient and give them a full six cycles of treatment. Now, in Hodgkin lymphoma, I think that the data are a little more clear that certainly end of treatment PET is important, and I think with any of these aggressive lymphomas, if you're not PET negative at the end of treatment, you're at a higher risk. The exception of that perhaps is a mediastinal lymphoma, where you can have some degree of PET positivity. And again, that highlights the issue of looking with your radiologist and making sure you're applying the Deauville criteria well, which many of these studies are based on. And those are not necessarily just numeric reports, but really there's a visual component of it a bit as well to it that one needs to have some expertise and put some thought into. So in Hodgkin lymphoma, I think and you've been a pioneer in this area, and I think it's great to see it come to fruition, the early negative PET scan really is something that we can use now. And in advanced stage disease, if you're PET negative after 2 cycles, we know now that you can drop out the bleomycin. If in early stage disease, if you're PET negative after 2 cycles, we know that you can cut to 3 or 4 cycles of treatment and likely avoid radiation. So I think the negative PETs after 2 cycles is really a big advance in the treatment of Hodgkin lymphoma.
The only one sticking issue, you're PET negative, but you had very bulky disease. Do you irradiate these people, or do you just simply observe them?
I think that I would observe those patients. If you had bulky disease but PET negative, I think the evidence of that needing more therapy or needing radiation in my mind is limited. Now you could again argue, which patient population are you talking about, knowing that these are typically chest lesions in young women. That's all the more reason to try to avoid radiation. And as time goes by and longer term follow-up is there, I think we need to be pushed a little bit more. Now, we have some data we haven't seen yet, and I think people are going to stay tuned for next year, because I see some of our debates at this meeting are going to be around the use of brentuximab vedotin as part of upfront therapy. And I think we've already, in our own minds, can divide up the next debate so that people are tuning in next year can find out our opinions on, do we use brentuximab vedotin as part of upfront therapy, because I think that's probably going to be an issue that will be of great interest to talk more about.
Certainly whether brentuximab vedotin can replace radiation as an adjuvant therapy.
Certainly.
Well, Dr. Leonard, John, it's been very informative hearing your views on today's session, and we thank you very much for those views. And this is Dr. Morton Coleman saying good day from Lymphoma Myeloma 2017, the International Conference on Hematologic Malignancy here in New York City.